This video is entitled Bone Anatomy Basics. It is designed to help understand the basic anatomy and structure of bone as applied to drilling the bone for the treatment of osteomyelitis and fractures. We will be using the radiograph of the tibia of an 8-year-old child as our example, since osteomyelitis is particularly prevalent in children. The standard radiographs used in clinical practice are an anteroposterior, or AP view, and a lateral view. The diaphysis of the bone is the strong structural mid-portion of the bone, constituting most of the length of any long bone. At the end of a child's bone is the epiphyseal plate, or physis. This is the growth plate of the bone made up of cartilage. On the X-ray, it appears as a lucent line. It is the weakest point in the bone in children, vulnerable to fracture. The younger the child, the wider the growth plates. At the end of growth, the epiphyseal plate fuses over and disappears, leaving a faint sclerotic line in adults to show where it once was. The growth plate fuses at about age 14 or 15 in girls and 16 or 17 in boys. The epiphysis is the end of the bone between the growth plate and the joint. It is structurally complex in order to shape the adjacent joint, and is covered with a layer of hyaline cartilage constituting the articular surface of the joint. The metaphysis is the flared end of the bone between the growth plate and the diaphysis. The diaphysis of the bone is made up of very strong cortical bone, providing the structural strength of the bone and allowing weight bearing. The medullary cavity of the diaphysis is largely composed of fatty tissue, with few trabeculae, or blood-forming marrow cells. The metaphysis of the bone has only a thin layer of cortical bone. The metaphyseal medullary cavity is made of spongy bone, called cancellous bone, constituting a woven network of small bone plates called trabeculae. The metaphysis is rich in blood supply and osteogenic cells. Surrounding the bone is periosteum. This is a membrane which covers the bone surface circumferentially. It is metabolically very active, with osteoblasts providing appositional bone growth that increases the diameter of the bone as children grow. The periosteum is structurally stronger and thicker in children and much thinner and weaker in adults. Understanding the various components of the structure of bone is important in understanding how and where it should be drilled in order to apply external fixators for the treatment of fractures, or create cortical windows to decompress and debride chronic osteomyelitis. Understanding the role of the periosteum is important in understanding how bone heals after fractures and infection. These important principles will be elaborated as we work through the rest of the Italo curriculum.